Thanks everyone for joining. So our first speaker for this session is Dr. Peter Knight, who is a professor of surgery at the University of Rochester School of Medicine in Rochester, New York, USA. Dr. Knight is a board-certified cardiac surgeon. He is also the chief of cardiac surgery at the University of Rochester. Dr. Knight completed his medical degree from New York Medical College and general surgery residency at St. Vincent Hospital and Medical Center. That was followed by a cardiothoracic surgery fellowship at the University of Rochester, where he is right now. Dr. Knight is a member of multiple professional associations, including the International Society of Minimally Invasive Cardiac Surgeons, the American Heart Association, the Society of Thoracic Surgeons, the European Association of Thoracic Surgeons, and the American Board of Thoracic Surgery. As an educator and leader, Dr. Knight has been awarded the Marjorie Morris and endowed professorship in cardiac surgery and is currently serving in the Dr. Jude Sower Family Distinguished Professorship in Cardiac Surgery. Dr. Knight has also been recognized for his clinical excellence, including winning the American Heart Association Mitral Foundation Mitral Valve Repair Reference Center Award. He has published 2 book chapters, more than 50 peer-reviewed journal articles, and an additional 50+ research presentations. Dr. Knight is our keynote speaker for this session. He's gonna share with us his experience and evidence on the bloodless surgery and the improvements of the outcome in cardiac surgery. Dr. Knight, please.
Thank you, Majid. I'll share my screen. Is everyone able to hear me?
Yes. Yes, yes.
I think I have the wrong setup. Hold on. Display settings. That should work.
Yes.
Okay, very good. Good morning, everybody, and thanks for this wonderful honor. It's a passion of mine for a long period of time. The annual conference for the Society is a wonderful experience for me. The title of the talk is Bloodless Surgery Improves Outcomes in Cardiac Surgery, Experience and Evidence. I'm Peter Knight, as Majid told you. I'm the chief of the Division of Cardiac Surgery here at the University of Rochester, which is in Rochester, New York. So the topics I just want to touch on, first of all, a little bit about Rochester and URMC, why we got started in this endeavor, some of the data on why this is important, the steps to success and failure, the preoperative tools, intraoperative tools, postoperative tools, and a conclusion. So when I tell people that are not from the States that I'm from Rochester, New York, they immediately think I'm from New York City, which is way down here. But it's about a 6-hour drive from that to Rochester, New York, which is on the southern border of Lake Ontario and is right on the border basically with Canada. This is the University of Rochester motto is Melior, which is ever better. And this is the undergraduate campus here in the foreground. Genesee River, the city of Rochester, and then Lake Ontario in the background. The medical center dominates the campus. This is the medical center. And the University of Rochester is now the largest employer in the city of Rochester. So we got started, a couple of things that just came together. First of all, in the United States, cardiac surgery utilizes approximately 10 to 15% of the nation's blood supply. So it's a big consumer of blood, and if blood is a precious commodity, so reducing the amount of use is obviously very important. But somewhere in the 2012 era, we were approached by members of the Jehovah's Witness community as they wanted us to try to build a more robust bloodless surgery program. And of course, cardiac surgery was the biggest user of blood in terms of the surgical program. We have a fairly large Jehovah's Witness community, and they were going into other areas, most notably in New Jersey, for bloodless surgical intervention. So in order to properly care for these patients, we needed to build a system that would provide high quality care and outcomes while respecting their faith. As it happens, one of the requirements of our training program, we have an integrated 6 residency program in cardiac surgery. The residents all need to be involved in a quality improvement project during their 6-year residency, ideally one project that lasts through most of their training. So that was really a perfect match for us. We recruited Dr. Amber Melvin, who was, I think, a 2nd-year resident at the time, to be one of the champions for creating this thing called an anemia clinic to serve the cardiac surgery patient population being evaluated as outpatients. Ultimately, the anemia clinic got rolled out to the entire surgical program, but in its infancy, it was a cardiac surgery plan. So what sets us apart from everybody else? You've seen some presentations of other surgical problems that can be pretty bloody, but the thing that sets us apart is the antiplatelet therapy and the heparin. So a lot of our patients are on dual antiplatelet therapy because they've had stents or other issues. A lot of them are preoperatively on anticoagulants like warfarin or apixaban. But intraoperatively, nobody does what we do, which is completely paralyze the coagulation system, running an INR that is a minimum of 480 seconds and frequently is over 900 seconds. And coincident with that, we run the blood through plastic tubing, which results in platelet dysfunction as well as some hemolysis, although the hemolysis problem has really been solved in most modern heart-lung machines. So that's a real challenge in cardiac surgery. So the question, this is a real question in my mind, and the discussion for these last couple of days really revolves around this. Obviously, the goal is bloodless, but I think it's actually less blood and bloodless together. The goal is bloodless, but reducing the amount is also very helpful. So to make this work, and other speakers have talked about this in terms of transfusion trigger, but basically the way I look at this is you should transfuse when it is life-sustaining, and the patient agrees to it, obviously. And I tell all my patients that we will only transfuse you when I believe that it is life-sustaining. To maximize our ability to meet the expectations of the Jehovah's patients, we have to treat them the same as everyone else. Of course, there's an exception that we have no backup plan like we have with other people. So if they are anemic and we can't get it solved in the timeline that the patients are looking for, we may have to delay, as there is no backup plan. But I think the important point is that you can't build a program for a subset of the population. You have to build a program that applies to everybody so that it is internalized in every step of the process. So what do we know for sure? Well, we know anemia is bad. We know transfusion is worse. But really, can we be sure of this? And I'm not sure that the answer has been developed yet, because the two overlap. More anemic patients are transfused than non-anemic patients, obviously. And if a non-anemic patient needs a transfusion, at least in our world, it almost always implies an intraoperative event of real significance and consequence. So I'm not sure you can tease the two of them out and decide what's worse. Anemic patients also have higher STS and Euroscore predicted risk of mortality. And so I think it's beholden on us to try to figure this out and decide what subset of the cardiac surgery population is most affected long-term after transfusion, and which population can we have the most impact on, because in the end, we're trying to help people. So this paper, Perioperative Transfusion and Long-Term Mortality After Cardiac Surgery, a meta-analysis, was a meta-analysis of 39 studies over 180,000 patients, with 61% of the patients being coronary bypass surgery patients, 42% received perioperative transfusion. And the early mortality was much higher in the transfused population, with an odds ratio of 3.9 with a significant p-value. Interestingly, and this has always been fascinating to me, and it's been repeated in multiple studies, if you look at the survivors of the procedure and look at their long-term survival at 6.4 years, there's still a reduced long-term survival. So not only is transfusion affecting the operative mortality, it's having a long-term impact on survival with an odds ratio of 2 and a significant p-value. This paper entitled "Fewer Transfusions Are Still More: Red Blood Cell Transfusion Affect Long-Term Mortality in Cardiac Surgery." This is a fairly recent paper from the European Journal of Cardiothoracic Surgery in 2023, March of 2023. It was a retrospective study, but based on prospectively collected data. And in Denmark, it's mandatory. It's a mandatory database. So it includes basically everybody getting cardiac surgery in Denmark. 43,000 patients involved in this study, and it was in CABG, AVR, and MVR patients. They excluded the deaths within the first 30 days. So they took out the operative mortalities to look at transfusion impact. And there were 32,000 patients left. You can see how it breaks down. 9,000 resulted in red cell transfusion and 23,000 no transfusions. And then they broke it down into two timeline cohorts: the early cohort, 2000 to 2009, the later cohort, which is 2000 to 2019. And the red cell transfusion rate went from 30, I can't really read it exactly, it looks like 37% down to about 20%. So almost a 50% reduction, which I think many places have seen as we ramp down the quote unquote trigger for transfusion, which used to be as high as 9 or so, and is now in many places 7.5, or in our center, 7 or a little lower than 7. But in any case, the circle part shows you not just the red cells went down in the two timeline cohorts from 41%, from 37% to 20%, the overall transfusion rate from 40 to 25, but even plasma and platelets went down. And this was despite patients being probably a little sicker, as the use of inotropes and vasoconstrictors went up a little bit during that same timeline. This is a more graphic illustration, and the upper panel shows a very steep decline in transfusions over time of red cells, which is the red line, and the green and orange are the plasma and platelet, but which also went down, but not quite as much because it didn't start out as much. But I draw your attention really to the middle panel, which is what I really want to focus on. So this is year by year, the number of units of blood transfused on average per year. And the red and blue, which account for the overwhelming majority of transfused patients, are 1 and 2 units. And that, in my mind, is where the protocols can impact transfusion. And you look at the green line, which is pretty small, but that's 7 units or more of blood. I mean, it's really hard to have an anemia plan preoperatively that's going to affect a 7-unit transfusion. Most of those patients have catastrophic events intraoperatively or postoperatively that result in this large amount of transfusion. And the colors are in between. But again, the red and the blue, which are the overwhelming majority of people transfused, are only 1 or 2 units of blood. And so techniques to reduce small amounts of blood, but using multiple techniques all combined, have a reasonable expectation of reducing that transfusion rate. Interestingly, and this is from the same paper, despite the marked reduction in the use of blood products, this Kaplan-Meier curves of survival based on transfusion, which is the solid lines in the 2 time periods, versus the dotted lines, which in the 2 time periods are superimposable. So no matter what, less blood, more blood, different time years, the impact is still significant in terms of 10 years survival. And we have to always keep that in mind when we choose a transfusion. So I asked this question earlier in my talk about, who are we talking about? Who's going to get the biggest benefit? And it turns out that the biggest benefit are on the younger, healthier people. So these are in 10-year increments, less than 60, or I'm sorry, 5-year increments, less than 60-year-olds, 65 to 69, 75 to 79, and over 85 years plus. And the survival curves are different are better in the non-transfused people no matter what, However, much more significant in the younger people, no transfusion versus transfusion, whereas in the older people, as you'd expect, the impact of transfusion becomes less at 10-year survival. And similarly, and comorbidities. So the sicker patients are down here, the healthier patients are up here, and in the healthier people, there's a marked difference in survival between transfused in the red and no transfusion in green. So if you're really sick and old, you're not going to get much of a return on investment in terms of 10-year survival. But if you're young and healthy, that's where the biggest bang for the buck comes in. So one of the gold standards in our business, as everybody knows, are randomized controlled studies. And this has never really been feasible in transfusion for obvious reasons. But there have been some randomized controlled studies looking at different transfusion triggers. And I'm sure everybody who's on this Zoom meeting is probably familiar with the TRIX-3 trial, which was supposedly restrictive or liberal red cell transfusion in cardiac surgery. And this was a multi-center, open-label, non-inferiority trial of 5,243 patients, randomized to restrictive less than 7.5 hemoglobin trigger versus liberal at less than 9.5. And I'm not sure in today's world that this would be considered truly restrictive, although it's probably true in some centers. But in our center, of course, it's less than 7. And I'm sure a lot of people are even less than that. And even at 7, we will pick and choose. Somebody who's doing fine, we usually won't transfuse, a 6.8 or 6.6. But in any case, these were the triggers in the operating room in the ICU, which is usually post-op day 1 to 2. And the primary composite outcome was death from any cause, myocardial infarction, CVA, renal failure requiring dialysis. And the endpoint of the study was either discharge or post-op day 28. So this was not an analysis of the long-term consequence of transfusion. And the result was that the restrictive trigger, 7.5 versus 9.5, was non-inferior in terms of the composite outcome. So they went a little further. 6 months later, reanalyzed these patients. This was published in the New England Journal of Medicine in 2018. And the conclusion was in patients undergoing cardiac surgery at moderate to high risk for death, a restrictive strategy for red cell transfusion was non-inferior to liberal strategy with respect to the composite outcome of death, myocardial infarction, stroke, or new onset renal failure requiring dialysis. So this, I just snapped this from one of our electronic record charts in a patient who was preoperatively in our ICU getting worked up for something. I don't even know what it was, but we're part of the problem. And this is a perfect example of the problem. This is 2 days with lab studies basically being done every 8 hours. And there were more labs. I just grabbed this one from the chart to show you. And basically the labs are unchanged over the 2-day period of time, but we're repeating them every 8 hours. And the consequence of this is this. We went from hemoglobin of 8.5 to hemoglobin of 6.7, and we didn't even do anything yet. And so, despite being pretty obsessive about blood conservation, we're part of the problem as well as part of the solution. And I think we all have to keep this in mind as we order lab work, that bloodletting is not a good idea no matter what. There are practice guidelines in our societies, and this was the original guideline published by the Society of Thoracic Surgeons and the Society of Society of Cardiovascular Anesthesiologists. This started in 2007. It's been updated a few times. But of note, one of the things that they did include in this was the risks of blood transfusion, which I think really wasn't helpful because, as you can see, the risks that our patients think about, which is, infectious risks, transfusion errors, they're not very common. And I think it belies the real challenge of transfusion. So I don't think putting this in the paper was all that helpful. But the 1 in 100 non-hemolytic transfusion reactions is probably something we all see pretty commonly. But I think it's more than this. It's obviously the immunomodulation that occurs with transfusions that results in the long-term survival issue. So that's the problem, and what to do about the problem is the real question. So for us, We divide it into preoperative stage. When the key here is identification as early as possible of anemia, and then treatment of that anemia, which is where the anemia clinic comes in. And the anemia clinic is housed in our Center for Perioperative Medicine. And I can't state enough how important it is to have a collaboration between hematologists, the anesthesiologists who run the Center for Perioperative Medicine, and surgeons, because everybody has to agree that this is an important issue that they're going to devote their time to and make efforts to solve. In the ideal scenario, the patient is seen in the surgeon's clinic, which would be, for instance, in my clinic. We identify the patient as being anemic by checking hemoglobin and hematocrit. We develop an operative plan. We figure out whether they're on antiplatelet or anticoagulant medications. If they're anemic, further labs are done as well to further stratify the anemia. And then the patient is sent for the preoperative anesthetic evaluation as well as treatment of the anemia. And most of the time, as you know, this is iron deficiency anemia, and we give them IV iron infusion, which we have capacity to do in the anemia clinic. And that's something that developed over time. So our initial anemia clinic had no infusion center, but now we have an infusion center location that will allow us to transfer to give an IV iron at the same time. And then consultation with the surgeon may be needed to consider delay for surgery for hemoglobin optimization. And of course, we also identify pretty uncommon, but not rarely, hematologic disorders that need to be worked up. So it's had a lot of benefits, not just reducing transfusion, but also identifying other disease states that we might not have noted. At the same time, the preoperative anticoagulation and antiplatelet therapy are assessed and then managed in conjunction with the anesthesiologist, the cardiac surgeon, and frequently with a cardiologist to decide what the best timing is. But as you know, and everybody has talked about this, and it will be continued to be talked about, in a surgical scenario, the biggest factor is intraoperative, and I can't overstate the need for hemostasis, as that's the critical factor. And that smaller, preferably non-sternotomy incisions are also very effective, because no matter what you do, when you divide the sternum and then give them a sublethal dose of heparin of 400 per kilo and an ACT of 500 seconds, the sternum will continue to bleed no matter what. And even with bone wax and everything else that we use, there's still continued bleeding during the 3 to 4 hour operation. But there is no bone incision in thoracotomy, and so you can get that completely hemostatic at the beginning, and it maintains hemostasis throughout the operation. We use retrograde autologous prime. I'll show you how it's done and what that really is, and there's data to suggest that that's effective. We ultrafilter the blood in this heart-lung machine during the case if we have a lot of volume and the hemoglobin starts dropping. Obviously, use of sealants and hemostatic agents where appropriate can be valuable. Heparin and protamine titration for accurate dosing of these two agents. Routine use of antifibrinolytic agents to prevent or minimize fibrinolysis. Treatment of acquired diseases like acquired von Willebrand's that develops with aortic stenosis patients using DDAVP, as well as DDAVP in renal failure patients, because the renal failure patients have some impact on platelet function, and DDAVP probably works in that scenario. And then cell saver. And the cell saver, I just would mention that some of these techniques in the Jehovah's Witness patient require special attention. So in Jehovah's patients, it's not a transfusion thing per se, it's blood being out of the body and out of contact. So if you keep the blood in continuous contact with the patient's blood vessels, then you're allowed, that's acceptable. That's how the heart-lung machine is usable in a Jehovah's patient. And the cell saver has to be continuously hooked up in conjunction with the, in parallel with the patient's blood system in order for it to really be consistent with their faith. So this is a sternotomy. It's a giant incision. It's 18 inches or so, 14 inches. This is what a minimally invasive aortic valve incision looks like. There's no bone involvement at all, so the incision can be completely hemostatic right at the beginning, even with full dose heparin. This is a minimally invasive mitral incision, similar size, a little more lateral. So does it work? And there are tons of papers on minimally invasive cardiac surgery and its impact on blood loss and chest tube output postoperatively. I just picked this one because I brought this up because of Jehovah's Witnesses. This was a retrospective study of 63 Jehovah's Witness patients. 19 had minimally invasive cardiac surgery, 44 had sternotomy. On postoperative day 1, there was lower chest tube drainage, which was statistically significant. The day of surgery, the hemoglobin was higher, 11.7 versus 10.6. And the hemoglobin was higher on post-op day 1, 12.3 versus 11.2. Not a great paper, but it's repeated multiple times. The transfusion requirement is a little bit harder to prove because there's going to be less numbers of patients. And as I pointed out, a lot of patients wind up being transfused because of catastrophic events. And so anemic or not anemic, it's going to be hard to impact that. But hemoglobin is a reasonable surrogate. So retrograde autologous prime, what is it and does it work? This is a meta-analysis of 21 studies, 11 of which were randomized controlled trials. And it shows that the odds ratio of transfusion with retrograde autologous prime was 0.34. So you're 2/3 less likely if you have retrograde autologous prime to require a transfusion. So but the question for you guys is, since this is what I do for a living and you guys don't, what is it? So this is the heart-lung machine, and there's a ultrafilter to get more fluid off. This is the reservoir for the blood. This is the oxygenator down here. This is all the tubing, which goes back to the patient. The patient's over here. And it's all primed with crystalloid. And there's about 1,500 cc's or so of crystalloid, which is a significant hemodiluter. And, in a large human, it wouldn't be that big a deal, but in a smaller person, especially someone who's starting out borderline anemic, it's going to have a big impact on hemoglobin immediately. And so what we do with retrograde autologous prime, and I'll show you the video, what we do is basically we allow for the sound. Let's stop in a second. We allow the patient's own blood pressure to push back the crystalloid into a bag, and we fill the whole thing with blood. So the heart-lung machine is not started yet. The connections are all made. The arterial cannula is in. You can see the blood's coming back right here through the filter, coming back into the oxygenator, which is down here. It'll fill the oxygenator slowly. And while it's doing that, what's happening is the fluid is being pushed out into this bag right here. So we'll fill the oxygenator, displace all the crystalloid, ultimately displace some of the blood from the reservoir. And then when it starts turning into blood, which is right here, that's when we shut it off. And then we have this big bag of crystalloid.
Finish with wrap.
The other thing we use when we have borderline numbers in on pump and we have enough volume is this ultrafilter, which is basically like a CRRT filter, and we can get blood back from that. I'm sorry, fluid back from that. So you can see the oxygenators and reservoir are fairly full, and we're using this to get crystalloid out, and that's a bag full of liquid. So we can maintain the hemoglobin even in anemic and pretty small BSA patients. And then with regard to specific disease states, as I said, antifibrinolytic agents in all procedures requiring the heart-lung machine, which is almost everything that we do. We do some off-pump stuff, but most of the stuff requires the heart-lung machine. DDAVP for aortic stenosis has been shown to work. DDAVP for renal failure has been shown to work. This is a paper from the Annals of Thoracic Surgery in 2011 showing 0.3 micrograms per kilogram of DDAVP and a reduction in blood loss of about 180 cc's on average in patients with critical aortic stenosis. And I would emphasize that it's like saving for retirement. You can't save for retirement with one big event. You got to save for it every day. And in the reduction in transfusion business, you don't save a liter. You save 100 cc's here, 200 cc's there, 300 cc's there, and pretty soon you got yourself a liter, and all of a sudden you haven't had to transfuse somebody. But these are all relatively small numbers, but added up, if you just have a focus on it, added up, it will work. So back to my agenda, you now know where Rochester, New York is. It's not New York City. We're way away from that on the Canadian border. Why we got started was a push by the Jehovah's Witness community, but now it's been translated in institution-wide to all surgical patients. Some data on why this is important, some steps to success, and one of the ways that we fail, which is bloodletting in the hospital admission, preoperative, intraoperative, and postoperative tools, and then the conclusion. So by employing a multidisciplinary approach with standard protocols, anemia can be identified preoperatively and treated. Tailoring the operative plan to specific patient characteristics is helpful. Minimizing blood draws, both the number and the volume, is critical. I can't say enough about the teamwork. Keep the transfusion trigger low or even lower. Bloodless surgery is the goal, but if you can't do that, less blood will do when transfusion is life-sustaining. And Meliora, ever better. Thank you.